Your doctor told you 120 over 80 is perfect, but after 60, that number might actually be working against you. There is a specific blood pressure range that protects your aging brain, your kidneys, and your heart simultaneously. And most physicians still haven't updated their patients. Tonight, you'll find out the real number, the one a growing body of research says could mean the difference between living fully and slowly fading. Stay with me until the end, because the single most important piece of information in this video is something almost no one over 60 has ever been told. It involves a specific window, not a single number, that your body needs to function at its best after 60. One large-scale study found that people who kept their pressure in this exact range had a 42% lower risk of stroke compared to those chasing the old target. 42%. And yet, your doctor may have never mentioned it. I'm Dr. Margaret Ellison, a physician specialized in senior health with over 15 years of dedicated clinical experience. I've sat across from thousands of men and women over 60 who were doing everything right, taking their medications, monitoring their numbers, following instructions, and still having strokes, still experiencing dizziness, still watching their memory decline. What I'm about to share goes against what many in the medical community still teach, but I've seen it with my own eyes, patient after patient, and I refuse to stay silent any longer. Here's what most people don't understand. Blood pressure guidelines were built on studies that were heavily weighted toward younger adults. When researchers finally started looking specifically at people over 60, over 70, over 80, the numbers shifted, and not slightly. The target that keeps a 50-year-old safe can actually starve the brain of a 75-year-old. That's not a theory, eh? That's in the published literature. And today I'm going to walk you through exactly what that means for you, your medications, your mornings, and your long-term independence. Before we go further, I'm curious. How old are you right now? Are you in your 60s, your 70s, maybe your 80s? And when was the last time your doctor actually sat down and explained what your blood pressure numbers mean for someone your age specifically? Type your age in the comments below. I want to know who's watching. And if nobody has ever explained this to you the way I'm about to, type never in the comments. You'll be surprised how many people share that answer. Now, to understand why the old target can be dangerous, we need to understand what blood pressure actually does inside an aging body. Your blood pressure is the force your heart uses to push blood through your arteries to every organ, every tissue, every cell in your body. When you're young, your arteries are flexible, elastic, like new garden hoses. They stretch and bounce back with each heartbeat. But after 60, something changes. The arterial walls begin to stiffen. This is called arteriosclerosis, and it happens to everyone to some degree. It doesn't mean you're sick. It means you're human and you've been alive for decades. Here's what that stiffness does. It means your brain, your kidneys, and your heart now require a slightly higher baseline pressure just to receive adequate blood flow. Think of it like this. If you have a flexible hose, even low water pressure moves water through easily. But if that hose becomes rigid and narrow, you need more pressure to push the same amount of water through. Your aging arteries work the same way. This is why researchers at the National Institute on Aging and at major universities across Europe began questioning the 120 over 80 rule as a universal gold standard. Because for many seniors, aggressively pushing pressure that low can cause the brain to receive less blood than it needs. Less blood to the brain means more confusion, more dizziness, more falls, and over time, accelerated cognitive decline. Studies published in the Journal of the American Medical Association found that in adults over 75, lowering systolic pressure below 120 was actually associated with greater risk of adverse events, including fainting, falls, and acute kidney injury. So what is the real number? What does the research actually support for adults over 60? This is where it gets important. There is no single perfect number. What matters is a range. And there are actually two separate ranges depending on your age within the senior category. For adults between 60 and 74, most updated research supports a systolic pressure. That's the top number, between 120 and 135, paired with a diastolic pressure, the bottom number between 70 and 85. This range provides enough force to keep the brain and kidneys well perfused without placing excessive strain on the heart. For adults 75 and older, the evidence shifts again. Multiple large studies, including the landmark SPRINT trial when its data was analyzed specifically for older subgroups, suggest that a systolic target between 130 and 145 may actually be protective for certain individuals, particularly those with stiff arteries, mild kidney dysfunction, or a history of dizziness when standing. Now I know what you might be thinking, but my doctor told me anything over 130 is dangerous, and I want to address that directly. Your doctor isn't wrong to be cautious. High blood pressure is genuinely dangerous. Uncontrolled hypertension absolutely increases your risk of heart attack and stroke, but the key word is uncontrolled. The danger lies in chronically elevated pressure, not in occasionally sitting at 132 or 135, especially if lowering it further causes you to feel dizzy, weak, or confused. Here's the thing nobody tells you. The symptoms of blood pressure that is too low for your age can look almost identical to symptoms of blood pressure that is too high. Dizziness, fatigue, confusion, brain fog, headaches. If you're on blood pressure medication and you feel any of these things, the problem may not be that your pressure is too high. It may be that it's been pushed too low for your aging cardiovascular system. I remember Patricia, a 71-year-old retired school teacher from Atlanta. She came to see me after 2 falls in 3 months. Her previous doctor had her on 2 blood pressure medications, and her numbers were consistently around 114/70. By the old guidelines, that looks fantastic. But Patricia was dizzy every morning when she stood up. She had stopped driving because she didn't trust herself. She had stopped gardening, something she had done her entire life because she was afraid of falling. When I looked at her full picture, her age, her medication doses, her activity level, and the stiffness in her arteries that a simple ultrasound revealed, it became clear her pressure was being pushed too low. I worked with her physician to adjust her regimen. We brought her systolic target up to between 125 and 135. Within 3 weeks, she called my office. She told me, "Doctor, I stood up this morning and I didn't have to grab the wall. I went out to my garden for the first time in months. I cried out there. I just cried. That wasn't a miracle. That was her brain finally getting the blood flow it needed. And she was able to experience that because someone looked at her numbers in the context of her age." Now let's talk about the bottom number, the diastolic, and why it deserves just as much attention as the top. Most people, and even many healthcare providers, focus almost entirely on the systolic pressure, that top number. But after 60, the diastolic number tells a critically important story. Here's what happens. As the arteries stiffen with age, systolic pressure tends to rise while diastolic pressure can actually fall. This creates what's called a widened pulse pressure. If your top number is 150 and your bottom number is 65, that gap of 85 points is a major warning signal for arterial stiffness. Research published in Hypertension Journal found that a widening pulse pressure is one of the strongest predictors of cardiovascular events in adults over 60, independent of the individual numbers themselves. The ideal diastolic range for seniors is generally between 70 and 85. When the diastolic drops below 60 in an older adult, especially while the systolic remains elevated, the brain and heart muscle, which fills with blood during the relaxation phase of the heartbeat, may not be receiving adequate nourishment. This pattern is associated with increased risk of silent heart attacks and white matter damage in the brain, the kind that shows up on MRIs and slowly erodes memory and processing speed. If you take blood pressure medications and your bottom number has been trending below 65, that is a conversation you need to have with your doctor this week. Not next month, this week. If you believe what you're hearing right now could matter to someone you love, type yes in the comments. If you're still skeptical that the old 120/80 guideline might not apply to you, type 0. Either answer is valid. But I want to hear from you because your response helps other viewers realize they're not alone in questioning something they've been told for years. Now let's talk about morning blood pressure because this is where the greatest danger lives for people over 60, and almost nobody talks about it. Your blood pressure is not a fixed number throughout the day. It follows a predictable daily rhythm called a circadian pattern. For most people, pressure is lowest during deep sleep, usually around 3 in the morning. Then, in the 2 hours before you wake up, your body releases a surge of stress hormones, cortisol and adrenaline, to prepare you for the day. This causes a sharp rise in blood pressure, sometimes 30 to 40 points in a single hour. In younger adults with flexible arteries, this surge is managed easily. In adults over 60 with stiffer arteries, this same surge can be catastrophic. This is why the highest rates of heart attack and stroke occur between 6 and 10 in the morning. Not because morning is uniquely dangerous, but because the cardiovascular system of an aging person is least equipped to handle sudden large pressure changes. Here's what this means practically. If you take your blood pressure medication once a day in the morning, you may be taking it too late to protect yourself during the most vulnerable window. By the time the medication reaches full effect, that dangerous early morning spike may have already occurred. Research from the European Heart Journal's MAPEX study, which followed over 3,000 patients over years, found that taking blood pressure medication at bedtime, rather than in the morning, reduced cardiovascular events including heart attacks and strokes by more than 60% compared to morning dosing. 60%! That is an enormous difference from something as simple as changing when you take a pill you're already taking. Now, I want to be absolutely clear. Do not change when you take your medication without speaking to your doctor first. Some blood pressure medications are specifically formulated for morning dosing. Some need to be taken with food. This is not a one-size-fits-all recommendation. But if your doctor has never had this conversation with you, bring it up. Ask specifically whether evening dosing might be appropriate for your medication and your situation. This single conversation could be one of the most important health decisions you make this year. I remember James, a 78-year-old retired engineer from Chicago. He had been faithfully taking his blood pressure medication every morning for 6 years. His readings at the doctor's office always looked reasonable, around 130/78, but he had 2 mini strokes, what doctors call transient ischemic attacks, both occurring before 8 in the morning. Both happened while he was still in his bathroom getting ready for the day. His cardiologist had focused entirely on the average numbers without looking at the timing pattern. When James started wearing a 24-hour blood pressure monitor, the problem became obvious. Between 5 and 8 in the morning, his pressure was consistently spiking to 175, sometimes 180, before his morning medication had taken effect. We worked with his physician to shift his medication to bedtime. Within 6 weeks, his morning readings dropped significantly. That was 18 months ago. He hasn't had a single TIA since. He told me afterward, "Doctor, I thought I was doing everything right. Nobody told me the timing mattered. Now I sleep better knowing that my medication is actually working when I need it most." His story is not unusual. It's common, and it's preventable. Now let's talk about white coat hypertension versus masked hypertension, because this distinction can completely change the decisions you and your doctor make. White coat hypertension means your blood pressure is elevated when measured at the doctor's office, but normal at home. This is extremely common, affecting an estimated 20 to 30% of people who appear to have high blood pressure. The stress, the anticipation, the environment of a medical office triggers a real physiological response that raises pressure temporarily. Here's the problem. If your doctor is making medication decisions based solely on office readings, you may be taking medications you don't need. Unnecessary blood pressure medication in a senior can cause dizziness, falls, kidney strain, and electrolyte imbalances. Masked hypertension is the opposite, and in many ways, more dangerous. Your readings at the doctor look fine, even ideal. But at home, especially in the morning or evening, your pressure is consistently elevated. Because your doctor only sees the good numbers, the underlying damage continues unnoticed. Research suggests masked hypertension affects roughly 10 to 15% of adults who appear to have normal blood pressure, and it's associated with significantly higher rates of cardiovascular events precisely because it goes undetected and untreated. The solution to both problems is home monitoring, not occasional, not once a week, regular, structured home monitoring, and there is a right way to do it. Here's the protocol that clinical guidelines actually recommend. Sit quietly for 5 minutes before measuring. Do not have caffeine, exercise, or smoke within 30 minutes. Sit with your feet flat on the floor, your back supported, your arm at heart level. Take 2 readings 1 minute apart and record both. Do this twice daily, once in the morning before medication and once in the evening, for at least 7 consecutive days before any medical appointment. Bring that log to your doctor. Those numbers tell a more accurate story than any single reading taken in an office where you've just rushed in from the parking lot and sat for 2 minutes before someone puts a cuff on your arm. A validated home blood pressure monitor costs between $30 and $60 at any pharmacy. It is one of the most valuable health investments a person over 60 can make. Look for devices validated by the American Heart Association. Upper arm cuffs are more accurate than wrist devices for most people. Now, I want to hear from you. Have you ever been diagnosed with high blood pressure based solely on office readings, without ever checking at home? Or have you been monitoring at home and noticed your numbers are completely different there than at your doctor's office? Share your experience in the comments below. I read every single one, and your story could genuinely help someone else recognize what's happening to them. Let's talk about something that affects blood pressure dramatically, and almost nobody connects to it: sleep. Specifically, the quality of your sleep and whether you might have obstructive sleep apnea. Sleep apnea is a condition where your airway partially or fully collapses during sleep, causing you to stop breathing, sometimes dozens or even hundreds of times per night. Each time this happens, your oxygen drops and your body responds by flooding your system with stress hormones and briefly spiking your blood pressure. The reason this matters so profoundly for seniors is that sleep apnea becomes both more common and harder to detect as we age. Many older adults with sleep apnea do not snore dramatically. They simply wake up tired. They have high blood pressure that's difficult to control despite multiple medications. They experience morning headaches, or they have atrial fibrillation that keeps coming back despite treatment. Research published in the Journal of the American College of Cardiology found that treating sleep apnea in adults with resistant hypertension, meaning blood pressure that doesn't respond well to medication, reduced systolic pressure by an average of 14 points. 14 points. That is comparable to the effect of adding a second blood pressure medication from treating something that has nothing to do with the heart directly. If you're on 2 or more blood pressure medications and your numbers are still not well controlled, ask your doctor specifically about a sleep study. Ask whether sleep apnea could be contributing. This is a question that changes outcomes, and it's one that rarely gets asked. Let's now talk about the medications themselves, because certain common blood pressure medications have specific effects in seniors that every patient deserves to understand. There are 5 main classes of blood pressure medications commonly used in older adults: diuretics, which help your kidneys remove excess fluid; ACE inhibitors; and ARBs, which relax blood vessels by blocking certain hormonal pathways; calcium channel blockers, which relax the muscles in blood vessel walls; and beta blockers, which slow the heart and reduce the force of its contractions. Each class works differently, and each has different implications for seniors. Diuretics are often the first medication recommended, and they work well, but they come with a significant risk in older adults: dehydration and electrolyte loss. Sodium, potassium, and magnesium are flushed out along with the fluid. Low potassium causes muscle weakness and dangerous heart rhythms. Low magnesium contributes to insomnia, muscle cramps, and elevated blood pressure itself, creating a cycle that can be difficult to break. If you're on a diuretic, your potassium and magnesium levels should be checked regularly. Ask when yours were last tested. Calcium channel blockers are generally well tolerated in seniors and are among the most evidence-backed medications for people over 60 with isolated systolic hypertension, meaning a high top number with a normal or low bottom number. However, one type, the short-acting versions, can cause rapid drops in pressure that trigger dangerous reflex increases in heart rate. Long-acting versions are strongly preferred in elderly patients. Beta blockers reduce blood pressure, but also reduce heart rate and can cause fatigue, cold hands and feet, and in some people, depressive symptoms. They are important in people who have had a heart attack or who have heart failure, but as a first-line blood pressure treatment in seniors without those conditions, they are now considered less preferred by most updated guidelines. ACE inhibitors and ARBs are often ideal choices for seniors who also have diabetes or kidney disease because they offer additional protection for those organs. However, they can cause the kidneys to retain potassium, so monitoring is important. None of this means you should change your medications on your own. What it means is that you deserve to have an informed conversation. Ask your doctor what class your medication belongs to. Ask why that particular class was chosen for you. Ask whether your electrolytes have been checked recently. Ask what side effects are specific to your age group. You are not just a patient. You are a partner in your own healthcare. And knowledge is the most powerful tool in that partnership. I want to tell you about Dorothy, an 82-year-old retired librarian from Portland. She'd been on 3 blood pressure medications for 4 years, and her numbers were still inconsistent. Some days she measured 160 at home, other days 110. She was exhausted all the time, and her ankles were swollen constantly. When she came to see me, the first thing I noticed was that nobody had checked her electrolytes in over a year. Her potassium was dangerously low from her diuretic. Her magnesium was depleted. Her kidneys were showing early signs of strain. And she had never been evaluated for sleep apnea despite waking up every morning with a headache. Over the next several months, working closely with her primary physician, we addressed each piece: electrolyte supplementation, a sleep study that confirmed moderate sleep apnea and led to treatment, an adjustment in medication timing, and a structured home monitoring plan. 6 months later, Dorothy came in for a follow-up visit. She was no longer on 3 medications. She was on 1 at a lower dose, with better control than she'd had in years. She looked at me across the desk and she said, "I spent 4 years feeling terrible because I thought that was just what getting older felt like. Nobody told me there were pieces we hadn't looked at yet. That is the single sentence that drives everything I do. Nobody told me. That is no longer acceptable. Not for you, not today." Now let me give you the practical action plan you can implement starting this week. Step 1. If you are not monitoring your blood pressure at home, start now. Purchase a validated upper arm monitor. Follow the proper protocol I described earlier. Take readings twice daily for 7 consecutive days and record every result. Step 2. Bring that record to your next doctor's appointment. Specifically ask your doctor to review your target range in the context of your age, your other conditions, and your current medications. Do not accept a generic target without a conversation about whether it applies to you specifically. Step 3. Ask your doctor when your potassium, magnesium, and kidney function were last checked, especially if you're taking a diuretic. If it's been more than 6 to 12 months, request updated labs. Step 4. Ask about medication timing. Find out whether your specific medication might be more protective taken at bedtime rather than in the morning. Have this conversation. It costs nothing and the evidence behind it is significant. Step 5. If your blood pressure has been difficult to control despite multiple medications, or if you wake up tired despite adequate sleep time, bring up sleep apnea. Ask whether a sleep study would be appropriate. Step 6. Track how you feel, not just what you measure. If your readings look good but you're dizzy when you stand, fatigued throughout the day, or struggling with brain fog, those symptoms matter and they need to be part of the conversation. Don't make these critical errors. First, don't assume that lower is always better. After 60, blood pressure that is too low for your arterial health is genuinely dangerous. Second, don't skip doses or adjust your medication on your own. Changes need to be made with medical supervision. Third, don't rely solely on office readings. Home monitoring is not optional, it is essential. Fourth, don't ignore the morning window. Your riskiest cardiovascular hours are the hours most people pay the least attention to. Fifth, don't accept fatigue, dizziness, or brain fog as inevitable aging. These symptoms deserve investigation. So let's bring this full circle. We've covered why the 120/80 target was never designed specifically for aging bodies. We've talked about how arterial stiffness changes what your brain and kidneys need in terms of pressure. We've discussed the morning spike that kills people who don't even know they're at risk. We've examined how medication timing can reduce cardiovascular events by 60%. We've explored the difference between what your numbers look like at the office and what they look like at home. And we've walked through the specific questions that every person over 60 should be asking their doctor, but most never do. My main message today is not fear. It is not that your doctor is failing you. My message is empowerment. Now, you have information that most people never receive until something has already gone wrong. You don't have to be one of those people. Here is my challenge to you. This week, before you do anything else health-related, have one conversation with your doctor. Just one. Ask about your target range given your age. Ask about your medication timing. Ask about your electrolytes. One conversation, armed with the right questions, can set an entirely different course for the years ahead. Your body is not finished. Your cardiovascular system is not finished. It is adapting to the decades you've lived, and it simply needs your care and your attention to keep serving you well. If this video gave you something useful, please hit that like button right now. Subscribe to this channel if you haven't yet. And share this with someone you love who is managing blood pressure and may never have heard any of this. A single share might spare them from something devastating. And tell me in the comments, what was the one thing you heard today that nobody had ever told you before? I genuinely want to know, because this conversation doesn't end here. It continues in every comment, every question, every story you share. Take care of yourself. You've earned it.